I'm dying. Martha, I was dying yesterday when you were like, you were like that.
Hear my voice?
I was dying.
I went to bed at like 9.
So it's 9:30, so we're gonna get going. There's a lot to cover today. I did, if you were able to listen to the voice PowerPoint that was, we asked you to keep in hand. I did say we were doing class activities and a case study. And I've got to renege on that. That's not happening today just because there's quite a bit of material to cover. If you did download the case study, you worked it. I doubt you did, but if you want to work on the case study as a study guide, I will post the answers for the case study. Okay? That's the good back because I really don't think I'm going to have enough time today. And I feel like I owe you a little bit of time because I asked you to do a voiceover for our class. So if we get out a little bit earlier, we'll do the test review whenever we get out. Does that sound fair? Yes. Okay. So today we're talking about Parkinson's disease and alcohol use disorder. Parkinson's is considered a 1.5-hour class, so how many questions do you think you'll be sitting on this exam, on exam 5? A lot. 9 to 11. These was 2 hours. I said it was 9 to 12,
Yeah,
right? 6 to 8 is a good time frame for any 1-hour class. So I always start off with this class. I've been doing this class for a long time. It's one of my favorite classes, Parkinson's. We're talking about the concept of fault, right? Mobility. Okay? And I always start out the class by asking, what do you notice about the pictures up here? What is common? What is the commonality about all
They're
men?
men.
They're all men. They're all older men.
All
right?
the men.
Okay, do you notice that?
Yes.
High foreheads? Okay. A lot of white guys I heard down here, right?
Yeah.
What else?
Probably. They're old.
Do you know any?
They're all famous. They're famous.
Famous? Anything else?
They're white. Actually, they all are.
The majority.
They're older. They don't have one.
A lot of them have a handrails.
Do you notice anything specific about these guys? Not being older and white. What do you notice that's specific about certain pictures up here? Anything? Muhammad Ali, let's take him. He did. So there's trauma related to his, right? You're relating trauma to his Parkinson's disease, right? How about Ozzy Osbourne?
Drug use.
Drug use, that's what they're relating his Parkinson's to. We don't know what causes Parkinson's. We do, that was a question this morning, right? We know that it is a cause of what? Decreased dopamine.
Depression, yeah.
That's all we know. We know that there's Lewy bodies in the brain afterwards. That's really
I didn't either.
what we know about Parkinson's, right? What do we know about Michael J. Fox?
Young.
He developed it young, so progression is slower when you develop it young, right? He looks pretty bad now. The latest, I was gonna post a video of him. I usually post a video of him. I read his Lucky Man. It's even if you don't read it for Parkinson's, it's a great book. It's a great book about hope. Okay. So he's not looking all that great now because he's getting a little bit older, right? Major player in Parkinson's. He has his own foundation and gave billions of dollars, right? To the disease process, to research. Okay? Who else do you see up here that is familiar to you that had a bad outcome from Parkinson's disease?
Robin Williams.
Robin Williams. That he speaks to the depression part of the disease process, right?
Never knew he had.
Well, they're relating. They're saying he had Lewy bodies when he had his autopsy. So they're like back and forth. But they did diagnose him with Parkinson's, and as we move like through the PowerPoint, you're going to see that if
Isn't there Lewy body dementia though?
Yeah.
there is Lewy body dementia, so they were kind of relating it to that. But the Lewy body dementia would be related to Parkinson's as well. So they're not. He did get treated with it from what I heard, and he got a response. The main, we're going to talk about it more, but the main treatment is what for Parkinson's? Cinnamon. leave it over, right? If you, and that's a really indicator that if you start taking that, that's an indicator that you probably have Parkinson's. And it works, right? So you probably have Parkinson's disease. Okay?
Did you say that it works well? Like it works?
If it works.
If it works, I'm sorry.
Yeah. So our objectives are talking really about mobility today. But we're also talking about the non-mobility signs and symptoms. Oops, I didn't mean to do that. But now that we're on this slide, let's talk about it. Here's the concept map. It just talks about the interrelated concepts with visual for you to what you're studying. Okay? So Parkinson's overview. It's a progressive chronic neurological disorder. Why is this moving? Crazy thing. Sorry. It's a progressive neurological disorder. It's chronic. It's slow progressing. Diagnosis increases with age. So that, as you saw in the front PowerPoint, 60 years, usually diagnosed after 60 years of age. Starts with a unilateral hand tremor and progresses to a bilateral hand tremor, rigidity, bradykinesia, and postural instability. So the early signs is a unilateral hand tremor. Sometimes people don't even know it until they start, like they're writing something or they go for a physical at a doctor's office, and then the doctor picks up on, does a good physical and picks up on early signs of Parkinson's, and then we start treating. 500,000 individuals in the United States have it, and it costs $6 billion annually. So what is it? What's the pathophys? There's decreased dopamine, there's decreased neurons in the substantia nigra, there's decreased ability to control complex body movements. As I said earlier, Lewy bodies are a byproduct of protein they're found on autopsy. We're really not sure about Lewy bodies or how it plays a role in Parkinson's, but it's noted on folks that are diagnosed with it. So we talk about the two neurotransmitters, acetylcholine and dopamine, acetylcholine being the excitatory neurotransmitter and dopamine being the inhibitory. The problem is with dopamine, okay? Risk factors, if you're a man, there's a higher risk factor. If you're older, there's a higher risk factor. Environmental, certain professions are at higher risk. I have a picture of farmers on here because farmers exposed to pesticides and herbicides, and we talk to you about environmental health, but there is a link between pesticides and herbicide exposure and Parkinson's disease. Okay? I did post a video about my brother, me and my brother and I online. It is worth your time to watch it. It talks about the genetic factors, talks about really the disease process the two brothers going through. I think it's like an hour long, if I remember correctly. But two brothers going through Parkinson's diagnosis together. It's pretty good stuff. But that relates to the genetic factor in Parkinson's. Okay. Prevention. The cause is really unknown, but there are some studies out there that tell us that healthy diet, high in fruits and vegetables is good to prevent Parkinson's. Moderate amount of caffeine. Avoid the herbicides and pesticides. The foods treated with the herbicides and pesticides, so you want to be buying organic fruits and vegetables. Consuming nutritional supplements like vitamin C, D, and E, coenzyme Q10, creatinine, and stilbens. What are stilbens? Anybody? Any ideas? They're found in berries, grapes, nuts, cocoa. So if people are consuming those type of things, that's a good thing. Also, flavonoid-rich fruits, found in berries as well. Tea, red wine, and eggplant. So the motor signs of Parkinson's, you have 2 out of the 3 classic signs signs for a diagnosis of Parkinson's disease. Tremor, which is again usually unilateral at the start, can be accompanied by pill rolling. You've seen patients on, a lot of times patients with psychiatric illness will do this, and it's just that this is what it is, right? There's also, you might see hand flapping back and forth. Okay? Those are considered tremors as well. And then tremors, like some of you might have been doing the SEWA scales already and seen some tremors like this. But in Parkinson's, you might see this as well. Okay, so the pill rolling. As it progresses, it can go to the both hands, the arms, the legs, the face. And tremors are usually exacerbated by a stressor. Some type of anxiety, some type of stressor. Yeah. Rigidity is resistance to movement due to involuntary muscle or muscle contraction, so they're tight, they're rigid. Okay? They talk about a cogwheel movement with Parkinson's, and you'll see the physical therapist testing this, right? So what it is, do you guys know what a cogwheel is? Some of you? Yeah, you're doing it right now. You're like, yeah. So it's a resistance to movement as you're going, right? The physical therapist will pull on the, like if I pull on my arm, this comes right like this. They resist the movement as they go. Okay? That's cogwheel resistance. Bradykinesia, what is that? Painfully slow. Anybody here treat someone with Parkinson's? Not treat. We don't. Anybody take care of a person with Parkinson's? Can you describe what they look like?
Stumped over, they shuffle the feet.
Stumped over, shuffling.
Some
Sun's freezing, right? They freeze, right? And drooling. Drooling because of facial muscles, right? We have some rigidity and mass-like face in the face. Yes.
they need, like, once they get up, they need something to hold on to.
They do. That's a very important part of their, and we're going to talk about that when we talk about the interventions, right? When you have someone who has Parkinson's, you make sure you have a chair, a solid chair, right? With arms, because they need something to hold on to. They cannot, because of the rigidity, because of the bradykinesia, because of all the symptoms, but also because of the postural instability, right? Because once they need to push off in order to get up. Good. I'm glad you saw them. Now, and again, I say this to my clinical group all the time. Like we'll see something. When I get excited about something, it's just that you're seeing it in the clinical environment. Okay. Anybody else take care of someone with Parkinson's? A blank stare, a mask-like face, that's the rigidity in the face, right? You might see the tremor as well sometimes. Okay? So you want to, let's talk about the postural instability. So they can't keep themselves straight. They can't keep themselves up. That's why you see them hunched over a lot, right? That is a potential for fall. These guys are absolutely our exemplar for fall guys. Yes. You grab a chair. Start, right. Yeah, that will happen. You have to be careful. That's why we make sure that we have a physical therapy consult on these guys no matter what. Now, they're not traditionally in the hospital, right? They're not traditionally in the hospital. This is a comorbidity. But if you have someone who has Parkinson's and you see they're on Senate, where's Jimmy? Are you here, Jimmy? Okay, he's not. Okay. Oh, you see? He's like, don't call me out, Professor Andrews. When you have someone who has Parkinson's, right? You want to be mindful of all the indicators. Can I tell them the story, Jimmy? Quick? Okay. We were giving meds to a patient who had Parkinson's, right? And so you guys run in and you look at all your meds that you got to give. You're like, I'm going to have blood pressure. I'm going to have this. I know this can be given with meds. I know this can't, like those kind of things, right? So Jimmy, I said, hey, Jim, he has Cinemet ordered at 6 o'clock in the morning. And he said, I didn't research that because I didn't, I wasn't going to give the medications, but it's still a medication for a patient with Parkinson's, right? So I gave him a break, I'm not that mean, but and I explained to him why I was ordered at 6 o'clock in the morning, okay? You gotta be mindful of all these things with comorbidities, because again, you're not gonna have a patient coming in with Parkinson's, for the most part, unless it's seriously bad, and you're at the end, you're moving 2 feet and all those kind of things. Okay? Make sense? Did you have something?
My grandma has Parkinson's.
She does.
When she gets up, she always tells me like it's like the ground is pulling me. Like
The ground is pulling her back because of the rigidity, probably,
yeah,
right?
it's so hard for her because she always like when she got up, she always has to have either her knee or
They need devices as, they need the walker, they need the cane, they need the chair, the raised toilet, they need all those things. We're gonna talk about more, but they do need those types of equipment. I keep coming out and talking to you guys, and I gotta be mindful that we gotta get through a lot of material, but it's, I get excited when you get applications. So just be mindful that the postural instability comes later in the course of the disease. God bless you. So tremor is the usual gradual onset, progresses slowly over chronic prolonged course. And then we talked about the slow, steady unilaterals that start off when they're diagnosed. And then it's rhythmic, and we talked about pronation, supination, and then the full only. And we talked about the rigidity as well. Okay, it's resistance of a passive limb, okay? Stiffness. We talked about the bradykinesia, it's abnormal slow movements. It's longer to complete a movement, and it's longer to initiate that movement. Postural instability is loss of your postural reflexes. So your postural reflexes are what keep you upright, keep you when you're walking, okay? They have that propulsive, which it's like a shuffle. It really is like a shuffling game. Okay? And there's retropulsion. What's that? Yeah, you fall backwards. Yeah, absolutely good. And then also festination. What's that? Yeah, they're running. They're like almost, like you'll see them shuffle, but then they're like this, right? You've seen them do, you've seen patients with Parkinson's do that. They're either trying to go really quick. That gives you another reason why you think that the patient's gonna fall, right? Because they're shuffling, but then they want to go, right? They have the postural instability, so then they're going back. Every part of movement in the walking is affected. They have freezing, right? Where they'll just stand there and they can't move. They can literally cannot move. What do you do? What's your nursing intervention if they're freezing?
Sit them down.
What's that?
Sit them down.
Try and sit them down, which is also a hard thing to do because they're frozen, right? So you're running and grabbing a chair. Usually when someone has advanced Parkinson's, they're with a physical therapist, right? And the physical therapist will teach them those exercises, like take one step forward and then a couple steps back, right? They'll also tell them you can step over something. They'll also use music or a timer or ticker saying, this is when you're supposed to be taking a step, right? What? To give them a rhythm of movement, right? So that they're thinking about that. And studies show that if a person who has Parkinson's is concentrating on something, they do much better with movement. I talk about Michael J. Fox a lot in this class. When he wasn't in his advanced disease process, he can ice skate. He was a hockey skater. He loved it, right? He absolutely loved it. So he had to concentrate in order to do that. And that's a tough movement. I can ice skate still, right? It's concentrating on something, so that's why the physical therapists use those techniques. Okay? Questions? this is what a person looks like with Parkinson's, okay? All those things that we just described. Tremors everywhere, the mask-like face, flexed elbows, stooped posture. It's good visual. So the non-motor clinical manifestations, early signs are insomnia to start off with, right? They have decreased REM sleep, sleep disturbances in general are common in the early stages of Parkinson's. That's why you run into fatigue, irritability. Loss of smell is an early sign as well. Depression, I can't stress this enough, depression can be at any point of Parkinson's disease, right? Not major, like once they start getting into the major depression and psychosis, that's more a later sign. But you can have depression at any, why? It's a chronic disease. You can have depression in any disease that's chronic, right? So you gotta be mindful of those things and assessing your patients for it. Later symptoms are dementia, referred to as Parkinson's dementia. Emotional changes such as severe depression, fear, anxiety, social withdrawal, isolation, and at points suicide, which we have seen recently, through our lives. So we already reviewed this. Any questions about this slide? Because I'm not reading everything here. Orthostatic hypotension is common, so that should be in your care plan to be checking their orthostatic vital signs, right?
Is that more of an earlier sign of leaving orthostatic?
Usually later, because that's when you lose your postural, you lose all those, So usually later orthostatic hypotension, but we say later earlier, you can, you don't know where the person is sometimes, right? So you always want to be, if you have somebody who has Parkinson's, check their orthostatic blood pressure and pulse, right? It just makes sense. Yes?
Is the infections and the pneumonia, is that the immobility?
Yes. Yep. We're going to talk more about that. Infections, pneumonia is huge. Why pneumonia? What kind of pneumonia do you think these guys have? Aspiration pneumonia, right? Good. So some other complications of micrographia, which you can see right there, you can see the tremor in the writing on this, right? Dysphonia, what's that? They have an inability to speak, so their voice is slower. It's slower. Everything is slower in Parkinson's, everything, right? Except for that vested when they do get movement and try to run, right? But for the most part, things are slower because of the decreased dopamine. Yeah, it's slower, it's slower, and it's really hard to understand, so that gives you a communication problem, right? So what are you thinking about as far as some of your, if you're at that point, what are you guys thinking about if you have a communication issue? Other means of communication, right? You want to make sure they have a board or paper or whatever. Okay? Even those boards that have, when it's really bad and because we want to communicate with our patients no matter what, right? We want to know what they're doing and what their needs are. Even if you get one of those boards with the, you can point to it. This is how I'm pointing, you know what I mean? What can we do for you? And then you have that point when it's the later stages. Okay? Falls is at the bottom, it should be at the top. You are watching your patients for falls. What kind of fall precautions are you doing with these guys? What are your basic fall precautions? This brings you right back to basic nursing. What are your basic
Bed
fall
alarm, lowering the bed.
Low, locked, and loaded. Low, locked, and loaded. Right? Low to the ground, locked on the bottom, and loaded with the bed alarm. Every patient with Parkinson's. I don't care if it's early or late. Yes.
I got a question. So I know in some nursing homes now they're not using bed alarms for the reframes. So what do you suggest?
Are you kidding?
It's a form of restraint. They wouldn't even let me use cell phone.
I won't even let you use what?
be able to, not.
How is a bed alarm a restraint? You're talking, it's a verbal restraint. Okay, I'm not gonna be.
I know.
But that is crazy, Bill.
In the hospital.
You have someone, you could put your voice, you could put your voice into those things, right? You have a family member.
It is
This is a good discussion, guys, I really think it is, but we're gonna have to move on. It's an excellent discussion. If you have a family member, you can turn around and put your voice in there, right? The family member's voice, isn't that reassuring to the patient? What? Some of the things. I don't know what to say about that. We're gonna move on, okay? We're gonna move on, guys. Any questions about the complications? Any questions about the complications? So history and physical, we talked earlier about having 2 of the 3 triad signs. You can see the tremor, the rigidity, and the bradykinesia with 2 of the 3. Okay. Someone with Parkinson's, like especially early on, you really use a good history and physical because those early signs and symptoms like the hand tremor, it's like hand tremor and handwriting can be picked up and the patient can be treated early on. We all know that earlier treatment results in decreased disease progression. So we want to make sure if you notice any of these things on someone, you make sure that they get to their doctor and have a good H&P. Okay? We use the positive results to anti-Parkinson's drugs as an indicator that the patient has Parkinson's. Does that make sense? You understand what I'm saying there? If they take Parkinson's medications and they work, that can be part of the diagnosis of Parkinson's. We use the D-scan, radioisotope injected scan to rule out an essential tremor. Okay, and when you're looking at these scans, you see that yellow area there is where the dopamine is released. There's less of it. Okay, so there's decreased yellow areas. Looking for the blue part is the brain, and the yellow area is where the dopamine production occurs. Okay, so you don't see as much yellow areas there. MRI to rule out, and blood test to rule out other symptoms, and rule out the side effects of the drugs. Some of the antipsychotics, like Haldol and Slorazine, can have Parkinson's side effects, right? So if they're on the antipsychotic medications, you want to rule that out as being the cause of the Parkinson's symptoms.
Our symptoms were probably part of the medication because it was every time
Can you guys hear? This is really good. This is good. Can you come in?
So my aunt was having a lot of symptoms, a lot of tremors and stuff like that, but she has been on psych meds for many, many years. So they're constantly changing her medications. So she started with like these really bad tremors, and I said, Lindy, you need to go to the doctor and talk to him about how strong the symptoms are since you started these meds. So 4 months later, 4 visits later, I ended up having to go with her because they were not listening to her and her symptoms. Eventually, her lithium level was so high that she was at a toxic level. So it's frustrating when they don't listen.
It's frustrating whenever the doctor doesn't listen in general, right? That's rough because it's a longer period of time. So now that you guys are nursing students, soon to be nurses, you know enough to like you went with her and you were like, okay, this is enough. It's been 4 months, right? And you advocate for your family. I was talking to my clinical group the other day and I said, listen, you guys, they're all coming to you. Everybody you know in the world is coming to you because you're the nurse, right? You're the person who knows this information and you're the person who knows to advocate for patients and your family as well, right? So that is frustrating, but we want to make sure that in the case of Parkinson's, we want to make sure that it's not the Parkinson's as opposed to the antipsychotic medications causing the trauma.
She got a diagnosis with it.
She got diagnosed with Parkinson's?
But
Okay.
it wasn't Parkinson's, it was medication that we didn't have Parkinson's.
That's called a Parkinsonism. Yeah. So they gave her Parkinson. And they'll reverse it when you take away. That's where. Oh, thank you for bringing that up, because that's where you can take away a Parkinsonism diagnosis, because those are the things that are going on in relationship to medications. So that's why you rule these things out. Okay? Does that make sense to everybody? So collaborative care, we're looking at surgeries, which is ablation surgery. They do burr holes up to the upper picture. They do burr holes into the head. It destroys the area of the brain causing the symptoms. We don't do ablation that much anymore. It's mostly changed. They mostly use DBS, deep brain stimulation. And that's where they place electrodes in the brain, in the area that causes Parkinson's, right? And they will stimulate it so that it will produce more dopamine. There usually is you can see here, can you see this bottom picture? Well, that's where the transducer is. It's implanted in the chest, right here. These are where the electrodes are. It goes all the way up and through. And the patient can have control of this, right? It's really nice because the patient can control the transducer in some way. I know it's inside the chest. I'm not sure how they do that, but the patient has a lot of symptoms. They activate their DBS system in their chest. Okay? Be mindful of just, you want to look at the site, make sure the site's good. It's kind of like a portacath that you can be checking out, you will be assessing anyway. So be mindful of, that the site, the skin around the area is nice and clean behind the cat. No redness, no swelling, those kind of things. Pharmacological therapy. I had complaints first thing this morning about pharmacological. You guys don't like meds anymore. Here's the thing, right? Meds are a huge part of nursing. Carbidopa and levodopa are the mainstay medications for Parkinson's. They're going to this first. It's dopamine, right? It's what the body is lacking. Cinnamon is a combination of carbidopa and levodopa. This Cinnamon is the most effective. But the problem is there's benefits are greatest in the first few years, and then after a while, if they don't work as well when you move to the other medications. The problem with the other medications is there's a lot of side effects from them. Okay? So this guy, not as bad really if you think about it, but it can cause dyskinesia, akinesia, those kind of things. Okay? There is the on-off effect. What's that all about? Any of you know?
Is it if you don't give it in time?
What's that, James?
If you don't give it in time?
No.
No.
I really said that, but that's wrong. Sorry, James. What's that? On-off is really, it is kind of a remission thing. It's like not really remission. The medication is working, right? You're taking your med at 6 o'clock in the morning when you're supposed to without food because you're worried about B6 and protein, right? You're taking it when you're supposed to, but then the patient will have symptoms not related to, all of a sudden, it's given at 6 and usually, sometimes later on, right? They'll start having symptoms and it's not related to when the medication is taken. So it's on and off. Does that make sense? No. Okay. It's not really they can get the med at 6 o'clock in the morning and have symptoms at 7. Does that make more sense to you? It's on and off. It doesn't work as well.
It doesn't work all the time.
It doesn't work all the time. It's not working for the patient. It's not consistent. It's inconsistent with the giving the medication.
So sometimes it works, sometimes it doesn't.
Correct. And it's not related to when the medication is given. Now, wearing off is a different thing that can happen with levodopa and carbidopa and cinnamon, is when your next dose is due and you start having the symptoms. So it wears off. The part of the med working wears off. Make sense?
Yeah.
Yeah. it's chaotic. It has nothing to do with when the medication's given. Sometimes you have it, sometimes you don't. We don't know. It's not necessarily a 7 again in the morning. Could be something different. It works and it doesn't work. It works and it doesn't work.
Yeah.
Questions, guys? You got the on-off and wearing? Yes? What's that? Okay. And I'll tell you why. I'll tell you why. We just don't want to give it with B6 or protein. We usually give, well, you give it at 6 o'clock because you don't want it with B6 in this is a pretty good question, guys. She says her patient doesn't take it at 6 o'clock in the morning, she takes it with breakfast or whatever, right? What you worry about here is giving you a B6 or protein because it decreases the effectiveness of the levodopa and carbidopa. So we don't want to do that. But her patient takes it in the morning with breakfast because she doesn't want the GI side effects, right? Because there are a lot of GI side effects like nausea, vomiting, those kind of things. So her patient takes it with breakfast, but is probably not taking her, B6 or multivitamin or whatever at the time. That makes sense? Okay. Was there another question over here? I thought somebody raised their hand.
Never mind.
I'm sure.
I was gonna say, is it a short half-life? Because I remember from the nursing home, a lot of people take this like 4 times a day.
Yeah, they do. That's good. That's a good. Yeah, they will take it at 40. There is a short half-life, so they will take it throughout the day. So you might get it at 6. You might get it again at 11 or whatever before lunch. It's in the hospital. It's traditionally before any food. Right, Jim? Okay. So you will have it a few times a day, twice, 4 times, it all depends. Here is just a chart of the other types of carbidopa and levodopa. I just want you to be mindful that it does come in controlled release. So that helps with your person's problem. So that they can take a controlled release just like any medication, right? And then they're not worried about taking it 4 times a day. It can be difficult to be taking the medication so many times a day, right? So they have controlled release and they also have injectable. So let's talk a little bit more about the many side effects. What kind of side effects have you guys noticed? Anybody? Besides nausea, a lot of it has to do with the GI tract, right? So severe nausea and vomiting, dry mouth, the postural hypertension that we talked about earlier, that was usually later in the disease. If you're taking this medication, you want to be mindful of that as well. So you're getting those orthostatic blood pressures. Constipation, palpitations, can cause hallucinations, and urinary retention.
One more time.
Sure. Severe nausea and vomiting, dry mouth, postural hypotension, constipation, palpitations, hallucinations, and urinary retention.
And this is with all of the meds or is it a specific
This is carbidopa and levodopa.
Okay.
Cinemat.
Is that why UTIs are common?
Bingo. Why else are UTIs common? Difficulty with hydration, right? Because they have a hard time swallowing. Why else are UTIs common?
Probably
They
get
can't
them
move.
clean.
They're not moving. What?
If they get them
Difficulty getting hygiene. That's a very good, retaining, yeah, urinary retention, yeah? Okay? So we did already talk about B6 and protein, a decrease in the effect of levodopa and carbidopa, and that's why. Why is carbidopa and levodopa given together? Why don't we pick straight up carbidopa, levodopa?
Carbidopa helps the levodopa.
Work.
Yeah.
Absolutely helps levodopa in the brain, yeah? Or dopamine, yeah?
But they're both dopamine?
No, carbidopa is a hormone. It helps the levodopa though. I forgot what the word is for that. Synergy, I don't know, whatever, it just helps leave it open, okay? So what kind of things can we do to help these side effects? What kind of things do you want to do as far as nursing goes to help these side effects?
Zofran.
Zofran, what up? Good for you, James.
Thank you everyone.
What else? Zofran, absolutely. What else? Bowel regime, urinary regime. What else? Stool softeners. What else? High fiber. Yes, thank you. What else? Hydration for dryness. Artificial tears. Mouth care. Again, we'll talk about this one more time. I'm going to say as far as food, right? If you take it with food, as long as it's not a protein, you can take carbohydrates, right? There are other forms of food besides protein. Just make sure you watch your protein. And they don't even really tell people stop taking protein. They just say don't take it around you, leave it open carb. What's that? No. You got something else in mind?
No, I thought,
It does help for the nausea and vomiting, so that's why, she gave the perfect example of it, that's why her patient takes it in the morning, right? And if you're gonna, so every medication thing is risk versus benefit, right? In every single medication you take, risk versus benefit. If you're gonna have the nausea and vomiting and not be able to, right? So you gotta weigh stuff, and that's why you come up with different interventions. That's why your care is specific to your patient, right? Good.
Well, they change the diet, even if they're not aspirating to soften consistency to help them with the or not?
Soft consistency, usually, like, especially when it's later, you could change it if whatever's gonna work. Nutrition is, you have a slide of nutrition. Nutrition's huge. So you can't change up the diet. Whatever's gonna work for your specific patient, right? Whatever works. As long as it's not, contradictory, right? Yes. No. I just want you to be aware that there are, and I'm glad you asked because I know the medication thing, if you guys are talking, and I hear stuff, right? You just need to know that there is an injectable form and there's a controlled release form. Okay? Because when you're given the medication, that's super important. I don't know how many times I've said to my students, all students, what's the difference between this low pressure and this, like, I'm just using low pressure, right? But if you give 180 of regular low pressure and it's not CD, you're going to have a big problem. So you just need to know that there's a control release. Good question. Anything else? Before we leave levodopa. Or cinnamon, no? Now, here's the other ones, all right? These guys are important. You will see some patients on older medications that have been known to have severe side effects, right? So you should know the basics as far as these meds go, okay? So the dopamine antagonists have side effects, same as levodopa. If there's nausea, there can be hallucinations and sleep problems.
Why would you want to pick a dopamine antagonist? Don't you want more dopamine?
Yeah, they work. I don't know why, but they work. They do work. Okay. Apomorphine is the injectable form of your dopamine antagonist. The bromoprimine, I can't even say the word. I know it as Parladil, right? You want to be seriously careful with it when you're giving that medication because it's really prescribed that some of the old timers come in on Parladil, right? God bless. So you want to be very careful because the side effects is fibrosis of the heart. That's never a good thing, right? So you want to be super careful. Sometimes the patients come in and you're like, why would they even give that? Why do you think they would give it? So continue to give it. It's the only medication that works for that patient. They've been on it and they do serial checks, like whatever, echoes, whatever, right? To make sure that there's not that issue. But you want to be mindful of it, okay? dopamine modifiers are also rarely used, Tasmar or tricapone. They're really used because they have liver issues. Can cause liver failure. The dopamine modifiers also make the urine brownish orange. So you want to be mindful of that. Okay? You're already checking out this person, you're already checking out the patient with Parkinson's because you're worried about UTIs. So if a medication causes something like that, you want to be mindful. If you see brown orange urine, you're going to be concerned, right? Oh wow, let's go see if he's at a dopamine modifier. Okay?
You said those were the talcapone and the incapone.
What's that?
You said that was the
That was one of the side effects, yes.
for the talcapone and the
Yeah,
incapone.
Tasmar. Yeah.
Okay.
The dopamine modifiers, the Tasmar is liver failure. The dopamine modifiers in general can cause your urine to be brown orange. Yes.
So the Tasmars cause liver failure?
Don't use it in liver failure patients, absolutely. If your patient has liver failure, they're not going to be on that med. Liver failure trumps Parkinson's, right?
The last one. Not from the word. I think it was that one.
That's just the tap one. Yeah. The liver failure. I'm going to say that again so everybody's clear. Tap, and again, I'm saying it wrong. Tap, yeah, is for, you're worried about liver failure. The dopamine modifiers, you could see brownish orange urine. And all of them. Yes. Okay. Everybody clear about those?
Yes.
Okay. Thank you for whoever said yes. I just want to be clear. I don't want to be like telling, you know, I don't want you guys to have questions. Yeah.
So, on the exam, are you going to?
I don't know, it might be there. If I'm speaking into you, it might be in the exam.
Well, I haven't finished my question.
You're like, she said no to me. I said no.
Like, would we have to know each individual one, or would it just be like the category?
No, dopamine modifiers for that particular, right? The individual one you need to know is which one? Chapone, right? Yeah. Tasmar, right? That's the one you need to know.
Yeah.
For liver failure in particular, which
And the rest just make it more
what do you want to know about the dopamine antagonist? Parkinson, all right?
So it's hard to
I know, I'll give you both names. If I ask you to listen, I give you both names, we've been giving, have we not?
sometimes.
I'll give you both names, I promise you. Oh, no, that starts a lot of talking. Are we good with the ones that you really need to concentrate on? Both of them you need to know the general category. You should know the general category, right? But the specific ones you want to know are what happens with Parladil and what happens with Tasmax.
Liver failure.
Okay? Know those specific drugs. You should. This is liver failure and cardiac fibrosis. It's not something to be like, right?
This is not
Yes.
No,
You good?
at the beginning.
No problem, James. You may see some other medications as well, the anticholinergics. You won't see them as much, they're not as effective. They're only effective in half of the patients, and the side effects are bad. You can have confusion, urinary retention, the anticholinergics. Confusion, urinary retention again, blurred vision. So severe side effects of the anticholinergics. And I'm going to say, you guys can read those names. I'm not going to list them for you, but those are the anticholinergics, right? We only use them in half, they're only effective in half of the patients, so you don't see them as much. They're older medications. You move to, what's the mainstay treatment for Parkinson's?
Cinema.
Cinemat. We're moving to these other meds only if the Cinemat isn't working. Usually Cinemat we go right, or they're having severe side effects. Okay? Sometimes they are getting together when we're later in disease process. That's good for you. We will add on when you get to later, you know, when you get to it's not working as much. Because I told you earlier that Cinemat only works
like
for
a
few
giant
years,
shirt.
for so many years, right?
It's so
And people are
sick.
older, they're
It's
still
so
on
annoying.
that right? Or even when it's an early diagnosis. So sometimes it will be multiple medications. But you won't, for the most part, you're not seeing these medications on their own. These other medications. Claire? Yes.
How would they prescribe anti-cholinergic since they have a urine?
Because it's risk versus benefit. Anticholinergics will help out. I talked about dopamine, right? So they can help out. It's really risk versus benefit, right? With medications and side effects. Drugs to control the non-motor symptoms. The antidepressants are there, the benzos are there, atypical antipsychotics when you do have some psychosis later in the disease process. Florinef is used commonly for orthostatic hypotension. Some of you have given it, right? Florinef, it works very well. And then the ditropin for bladder dysfunction. Okay? Lifespan considerations, if you have Parkinson's early onset, usually the disease doesn't progress as quickly. So we're talking before age 50. It's often inherited, slower progression, and lower rates of dementia with early onset Parkinson's. As far as women, you want to make sure that they, especially at the childbearing age, you want to make sure that the OBGYN and doctor are talking to each other because a lot of times the medications decrease, the contraception by mouth will decrease the effectiveness of the Parkinson's medication. So we need to make sure that there's collaboration there. Contraception will decrease the effectiveness of Parkinson's medications. So your assessment and patient interview. Make sure you're looking at their gait, their tremors, the symptoms, when they came on, what the duration was, what the severity is. Were they exposed to toxins or traumas, such as Muhammad? The response to the medication, do they have on-off effect or do they have wearing off? And be mindful of those non-motor symptoms. People with Parkinson's and chronic illness get depressed. Depression can lead to suicide, right? Depression can lead to other symptoms, other physical symptoms. So you want to be mindful of those non-motor symptoms as well. Your book has this United Parkinson's Disease Rating Scale, and it rates them according to 42 different categories. You just need to know of this. You don't have to know the 42 categories, okay? But if you look at the ADLs, motor, what they're doing, okay? And the complications of some therapy. Yes, James?
So it says Parlinol is an agonist, dopamine agonist.
It is. And it says antagonist up there, right?
It does say
I'm
agonist.
sorry.
Yeah.
It's
So
an
you
agonist.
change all of it to
Change
agonist?
it. Yeah, just change it to agonist. Yeah, I said antagonist, and I wrote antagonist by mistake. Thank you, James.
Oh.
It's an agonist, which makes total sense and answers your. Ryan, it's
Yes.
Yes, agonist, not antagonist. Right, it doesn't make sense. Ryan brought that up, and I'm like, oh yeah, that's what it is, right? But it doesn't make sense because you don't want to stop dopamine, right? Thank you for clarifying that, James. Your classmates. What?
Yeah, that's why I was like,
Okay, thank you for that.
okay.
And Ryan, point it out, too, right? All right, so what are our problems? Here's all listed here. I don't have to go through these with you, right? Questions? Am I missing any of the problems we discussed? I don't think so. I can be.
I was like that.
Nutrition, yeah.
Make sure.
So your implementation.
Okay.
All right, this is just a list of the implementation. We're going to go through we're going to go through all these actually, okay? Optimize active mobility, get your patient moving. They need to move. It's tough, they're slow, but you got to get them moving because daily exercise is evidence-based practice. It decreases the progression, it improves mobility, it decreases rigidity, and prevents contractures. So you want to get your patient moving. We talked about music in motion, and there's some videos out where people are doing their knitting, people are doing different chair exercises that have Parkinson's, and they're able to move much better. Balance, the special walking techniques, make sure they have their assistive devices. They need to have their walker, cane. You got to remove all obstacles and furniture. Make sure there's frequent rest periods. Wide base of support. Try to have them have a wide base so they're not shuffling, right? When you see them shuffling, they're doing this, right? Their legs are together, so wide base of support, and that helps also with the posture. If they're freezing, or if they're freezing when they're sitting, or they can't move when they start freezing when they're standing, have them rock back and forth. Sometimes that will get them moving. Why do you think that is? Again, they're concentrating on their movement, right? So you have them rock back and forth. Have them take exaggerated steps. Talked about stepping over an object. And also one step back and 2 step forwards. They're all walking techniques that has the patient concentrating on what they're doing, okay? And it really helps when they're freezing. We want to promote independence and promote self-care. You see all these assistive devices here. Trapezius bed movement, an armchair which was brought up over here, so the patient can get out of the chair once they're in it. Okay, you can use it to push off of as well. We want to make sure we have an occupational therapist on board, a physical therapist. We want to do all our patient teaching and family teaching, especially as far as safety. Any activity for a patient with Parkinson's takes forever. Nurses don't have that kind of time. You have 6 patients, right? They really can't sit there and help feed a patient. It's just not part of, you don't have that time, right? So make sure someone's there able to assist with feeding, whatever, any activity. Make sure you it's collaboration, right? Get physical therapy on board, get OT on board. Everybody who you can, you want to, especially when it's advanced, process, you want to get them on board, okay? Because you don't have that kind of time, and you know what? The minute that you shut someone down, it's happened to me. I'll be honest with you. The minute you say I can't do this anymore, they lose hope, right? We need to allot that time to them, and the way you do it is to have other people do it. Along those, qualified people. I'm not just anybody, right? Along those lines, you want to be mindful of caregiver role strain, right? Progressive disease, chronic disease, tougher caregivers, make sure there's some respite care in there somewhere. Improving bowel nutrition, bowel and bladder elimination. You want to monitor their weight, make sure they're maintaining. Supplements like Ensure and Boost, right? Be mindful of the complications in relation to the nutrition. What's the complication you're mindful of? Aspiration. They run into aspiration pneumonia. Talk to the dietitian, and in later disease process, we're looking at NG tubes and gastric tubes. For bowel and bladder, we're just establishing a regular regime, making sure that you're toileting them routinely, increase fluid and fibers, get your raised toilet seat, and skincare in relationship to UTIs, right? They're not able to take care of themselves sometimes, so make sure that the skincare is happening. Back to nutrition, you would also want to do calorie counts, right? And count how much nutrition you're taking in. You should be mindful of that. Because it can happen where they're not taking what they need. Because of all the things with eating. It takes for too long, they can aspirate, those kind of things. Swallowing difficulties are due to poor head control. They can't shake the food with their tongue in order to swallow it. There's tongue tremors even. Pharyngeal mobility is decreased. So you see these interventions. You can talk to OT or PT, home care people. They have trays, stabilization trays. They have tray mats that can go under the food. We also have those types of utensils where you can scoop up your, use a fork and then scoop up your nutrition. Okay? You're going to check with OT for all of these. Support and coping, you want to make sure that depression is common, you want to make sure that they get, the patient and the family members get the support and coping that they need. Chronic illness, progressive illness. Home care and community-based care, teaching and also, it's around the severity of the symptoms, okay? It's ongoing. And again, consider the possibility of caregiver role strain. It is a chronic illness. Questions. These are some tools that you can use for evaluating. You want to make sure you're evaluating what is going on with the patient. You want to look into disease progression. The pharmacology, we spent a lot of time on it. You want to be mindful of side effects, those kind of things. It's very important. And don't forget the isolation and sometimes the drug. Okay? Questions? Any other questions? Right? No, you're good? Are you ready for a break? Yes. Okay. How about, what do you got? 10 minutes? An hour. James?